systems. So I'll pause there for a second and ask, Joanna, did you want to reintroduce the topic if the recording just started?
Yes. So thank you everyone for joining today. We'll be talking about how our data, health data, is collected in Washington State, who collects it, how it's being used and manipulated, and at the end of the day, what kind of benefits do Washingtonians, the state, get from our data being collected. So we've started the panel. I've had a little bit of glitch with Zoom today, so we started the discussion on this particular slide. And then, Barb, did you have anything based from what you're seeing on your end in Skagit?
Yeah. So I want to answer who collects the data and how is it collected. So data is collected by various people, data analysts, physicians, nurses, public health practitioners. And it's collected either directly or indirectly. There's like surveys that patients have to answer. There's electronic data that practitioners refer to. There is environmental data, depending on like what area code are people living in, race, ethnicity. So how it's collected and manipulated depends on what it's being used for. In my profession as a EPIC orders analyst, I primarily deal with data from the electronic health records, as well as nursing providers and also self-reporting data from patients. So different people collect the data and then how it's manipulated. For me, specifically in my role, analyze the data and then I make conclusions based on that data. And then sometimes depending on documentation requirements or just to make sure that I'm, reporting everything that needs to be reported in case there's audits or all of that, we then incorporate some IT tools to help with that. Documentation can be really challenging depending on how much data you're using. So we employ like natural language processing. And then, that way we make sure we're capturing everything that needs to be documented. We know in healthcare, if it's not documented, then it's not done. So there's various ways to do it. There's various ways to collect it. It just depends what you're using the data for and what your end goal is or what you're trying to accomplish.
Great. So that's kind of a discussion or a topic around data collection and at the bedside. If we were to take the data that was being collected, let's say during COVID, I'm looking to Dr. Karras and Dennis, give us a few examples of how the data was used by the state, as it was being collected from the different organizations.
Dennis, do you want me to?
Yes, go right ahead. I saw your lips moving and then the mute on, so go for it.
So I think one of the what we call the bread and butter or the cornerstone of public health are reportable conditions, and in our state Washington authoritative code, there are certain diagnoses, highly contagious diseases, that the electronic laboratory results that are in all the systems that are maintained by HIMSS members throughout the state need to be able to report those results to the state and local health jurisdictions. And that lab test result is kind of the kickoff of important information that we need. but it's not the whole picture. And I'll talk about several of the other data streams that end up coming to Washington and Washington State Department of Health and became critically and incredibly valuable during the pandemic. So those traditional electronic laboratory reports are kind of the no-brainer. If somebody's got a positive test result for COVID, you need to let public health know so that it can become part of our reporting to the CDC. But it also triggers off a case investigation, epidemiologists contacting those individuals to figure out, do they need support services? How many other people may they have exposed and created contacts that need investigation themselves to try and move folks into quarantine and isolation if they're positive to prevent the spread from spreading further. So that's both the what, the why, and the how. There are several innovative activities that Washington is working on to kind of take those efforts up a notch. Electronic case reporting, ECR, is a relatively new HL7 format that providers can send not just the laboratory result, but a broader clinical picture of what's going on with that patient. And this will allow public health to dig in and see if there are people with comorbidities or other factors that might prioritize their investigation or the support to those individuals in the case of their COVID diagnosis. And then many of you may have the WAD Notify Bluetooth exposure notification system on your phone. That laboratory result or the positive lab coming in through ECR can trigger a message that goes out to that confirmed positive person and giving them the option to anonymously notify all of their close contacts that their phone has been near. And that kind of innovation is a non-pharmaceutical intervention that's possible because of that initial laboratory test result coming into public health. It's proven to be incredibly effective and resourceful at informing people of their exposures. But let's pass forward to a pharmaceutical intervention. Once the vaccines came along, obviously, so Washington State Department of Health operates the IIS, the Immunization Information System, the registry that all of your vaccine status gets entered into. And that resource, and we've got some colleagues from the immunization program in the audience here, so they can answer details when we go into a discussion. But that the IIS system became critically important in our response once we had that vaccine in our toolkit to combat the disease. And there's an HL7 message transaction to report in when you've gotten a new vaccine. It goes into the registry, but there's also a querying capability that providers can query the registry, figure out when is the person eligible for their booster or their next dose. That kind of coordinated interoperability really jumped up a notch in this during the pandemic. Pre-pandemic, we're seeing immunization queries, like a million a year pre-pandemic. And then post-pandemic, in 2020, when the vaccine first became available, we're seeing almost 3 million queries through our system. And then in 2022, I'm sorry, and that was in 2020. In 2021, we've seen our 12 million queries to the IIS through the health information exchange. It's incredible to see the utilization of information and making it available and accessible to individuals. That was the goal of all of this, and the goal of HIMSS is to create a process that improves the health of individuals, and seeing it utilized is really exciting.
That is cool. That's a big
yeah.
jump from 3 to 12.
Yeah, there are other things that we'll get back to. The opioid epidemic. We have the prescription drug monitoring program, which is another set of data that is collected and put into a registry, if you will, that helps better care coordinate people who are using controlled substances. Cancer case reporting is another thing that comes in as a valuable central registry, and syndromic surveillance, which I could go on and on about. It's one of my favorite topics to talk about, which is helpful in having our situational awareness of what's happening, what's the capacity, and how busy emergency departments are across the state. And for obvious reasons, that's something that's really important for decision making and figuring out how we need to respond. And in Washington, we've taken that technology and gone beyond just emergency rooms to understand hospital capacities and intensive care units. It really gives us some insight into what's happening in a way that helps us to respond better as an agency.
And when you say respond, that means creating new policies, perhaps, or having part in that role?
Yeah, it can go, depending on what data you're talking about. It can, and one of my colleagues, Ian Painter, is on the in the audience here. So I'll describe a scenario. We can take data that's coming in through these various surveillance systems, use that information to create models and predictions of what's happening, and using that information to make informed decisions in terms of allocating resources or requesting assistance, or putting in an order for more hospital beds or more ventilators to be delivered just in time. So there's real, it's not just writing a report and putting it in a PDF on a shelf that very few people read. It has a near-term impact on our ability to respond as a state. Having good information always does that. Ian, do you want to?
Sure. Thanks, Brian. Yeah, we use, throughout the COVID pandemic, we've used surveillance data in particular to create what are called infectious disease models that try and give us a better idea of what's happening with the pandemic. And then we can use those models to try and assess what might happen or what might happen in certain circumstances. And those models, or the results of those models, have been part of the decision-making process in terms of key decisions throughout the pandemic, such as masking mandates, or in particular lifting masking mandates, and so on.
Great, thank you for that addition. Right, Janice, did you have any input as well? I think you're muted.
Sorry. Hi. So on who collects the data, you mean? So I think it's interesting what you've been discussing, having served, for years on the data evaluation for King County, for the Healthcare for the Homeless Network, as well as Healthcare Authority, I had opportunities to bring forward issues that I felt were, and collectively from other patients or community members, what would be important to, what to measure and such. And so like we were talking about opioids, we could talk about buprenorphine perhaps as a frontline entry, right? And how to move into buprenorphine, how many people are on it, how much naloxone is prescribed, and issues like that, or co-occurring, whatever with benzodiazepines and such. So I worked at a state, federal level as well, and I met David Mancuso there. I'm sure a few of you on the call know who he is, and I was like, wow, this guy really knows what he's talking about. So I met him in measurement because I serve with National Quality Forum, and I've worked with a number of partners around the United States, bringing forward the patient and community, thoughts about what should be perhaps measured and how we can pull measure sets together. And I also serve on the Measure Application Partnership for the coordinating committee for NQF, which is measures that go directly forward to HHS. So I've learned a lot about the data there, and I feel it's very beneficial to have somebody like myself, a patient partner or community individual who isn't necessarily educated in the area of data, to be able to be providing input. And all through COVID, I did do this. I worked with the University of Washington in prioritizing research. They started a separate data group, broke off very early because we realized a lot of people were collecting data. And so I was primarily on the, standard type of research projects that would be inpatient or outpatient. And then I also work at a national level with something called COVID End out of McMaster, and it's global, who is involved. And I currently serve on the Evidence Commission. So I take what I learn locally, and I really give thanks to Washington State for giving me that opportunity to serve on the Healthcare Authority in the advisory for many years. I kind of stepped down. I'm still involved, but peripherally, and to be able to move forward. So all of this kind of ties into the social determinants of health, right? And a big thing I just want to add here, who collects the data is, really the patients are filling out surveys. If we're talking about the social determinants of health, there's some issues. And, this needs to be done in a very comprehensive, thoughtful manner. And I know a number of patients who really collect their own data, and they don't even use electronic, right? I'm with, I'm a data kind of geek. So I'm very appreciative of being able to have everything, my whole health record on electronic. But when you talk about who collects the data, I know patient partners, one just published yesterday in the NEJM, NEG, in New England Journal of Medicine, she's from Washington State, and she created her own diabetes one, a monitoring system. And so her name is Dana Lewis, if you're interested in looking it up. So patients themselves can actually bring forward, when they see there's gaps. And I think that's something important, in why is it collected. I think patients sometimes see why data needs to be collected, and they can collect their own and bring it forward at different levels. Thank you.
I'm reminded of, what comes to mind is when we talk about why are we collecting data, I think about the 1115 waiver that the Healthcare Authority is operating under. So it's essentially tells the federal government, we have a regional interest in improving population health. So we want a crack at doing this the way that works best for us. So, what we've done in the past with it is transforming health through the accountable communities of health. That's measure number one. The second one is supporting older adults and family caregivers. And then there's foundational community supports. The substance use disorder IMD part of that helped us lower administrative burdens for providers. There was also the mental health IMD waiver component of that. That feeds into expanded bed capacity. So when the question is, why are we collecting data? It's in part to prove that Washington can better utilize those dollars in a more in a sense that's more regional and that works for us. And then building on that, we have applied for a waiver expansion, and the measures that are in that, and you can find this on our website, include expanding access to care. So includes postpartum coverage, reentry coverage, and then another aspect is advancing whole person care. So that includes things like older care for adults, long-term services and supports. And then the third component is something that there's another acronym, taking action for healthier communities. And this would lead toward improving community-based care. So that kind of feeds into the social determinants of health that Janice was talking about. And so that's right now in the approval process. So fingers crossed, when that comes back accepted, then we'll get to continue the great work that we're doing. But I just wanted to also point out that when you talk about those social determinants, Janice, that ties in with this, doing what's right regionally for the people in our state. We know how to take, we've been allowed to do this for a few years now, and hope to continue it again, fingers crossed, when the Medicaid waiver comes back and we can do it for a few more years.
Great, thank you. Anything to add, Barb, on this before I move to the next slide?
Yeah, one last thing. When you say, where does this data go? Just wanted to reiterate that this data then goes to, helping us make informed decisions, and also can be useful in, quality improvement, as well as getting rid of disparities that exist. So most certainly the data does serve a purpose. It just doesn't sit there and then, just get tossed away. So definitely helps us make informed decisions, and then helps us improve our systems that we have in place too.
Great, thank you. And it looks like Janice had pasted a link on a few resources that we can follow up on.
Yeah, I'll just follow up. Dana Lewis, she had diabetes and created a do-it-yourself. Anyway, so she's really taken it on by herself, and it's really, really incredible what she's accomplished. And I was on Robert Wood Johnson Foundation grant with her, and I just want to add, I added the transformation grant, or the 115 waivers, Dennis, that you mentioned. And I was involved with some of that very early on, because I was involved with affordable housing for a decade before I moved into health research and quality and evidence-based medicine and such. And so I saw where, the waivers really helped in working with the healthcare authority, how we've been very innovative in that area is what I want to say. I think Washington State has been one of the most innovative states in the area of 115s. But when you look at other states too, you can learn from other projects that we could pick up and, and also, bring here that could benefit our population. So I hope other people from other states might be on and learn something. Thank you.
Awesome, thank you. So poll question number 2. Are you concerned about what and how your health data is being used? And you can put that in a chat. Nobody's answering. One person. Dennis says yes. Thanks, Dennis.
Yes, of course I'm concerned. I'd be lying if I said I wasn't concerned.
Peter says it depends who's collecting the data. So that's, I guess, another question is, how do you know? I mean, there's some instances where it's being collected, but then I'm sure there's some where you don't know that it's being collected. That's a good answer. Yeah, I would say I'm concerned too, and how it's being used. but learning about how it's being used from the previous discussion has actually helped alleviate a lot of that concern. So that's great. Thank you. All right. So I know, Janice, you had mentioned that Washington State is a leader in management of health data, and you mentioned, especially in respects to the waivers. Do we have other examples on where Washington is a leader in how we're managing our data?
In measurement, I'll just quickly answer
Yeah.
that. We are leaders in some areas in measurement, and I was involved nationally with the Innovative Accelerator Project, which developed out in 2016 measure sets for substance use disorder, beneficiaries of complex needs, physical health, behavioral health, integration, and long-term services. For each state could kind of choose what they'd like to use. But we were already collecting some of that data beforehand. And I do know that if I mention nationally, that I'm from Washington, they're like, oh, wow, well, they're really out there. I mean, that we're advanced, quite a bit more than other states in health data. And so I think that what I've seen in health data from an individual who also is involved, peripherally with public health and as well as clinical, is that I think our state, both the Department of Health and Healthcare Authority, as well as, like Skagit Valley, the different jurisdictions really do utilize county by county level as well, the data that they collect. And I think we do deeper data here, on demographics and others, different languages, statuses. And so we're able to work at a local level and tackling some of the issues as they arise very quickly, which I believe is really kind of the goal, for health data.
Great. Barb, have you been involved in any projects specifically around the use of the data that's been collected from Skagit?
I can talk to my previous role at UW Medical Center with the onset of COVID, and when Washington was the first place that everything kind of just went crazy at the beginning. What makes Washington a leader in the management of health data is just being there and seeing how different organizations collaborated to make sure that we were creating tests, to make sure that the communities were getting access to these testing. I mean, people didn't have to pay for these tests for a while. Also, when it came to the rates, positive rates were pretty high, and everything just kind of kept improving over time. Generally, Washington is known to be one of the states that has really good healthcare systems. So all of this is not possible if we don't have data, and if we don't have quality data. And quality data is super important because we don't want to make flawed decisions. So I think what Washington does well is prioritizes data, prioritizes people, and really just that collaboration. From all previous jobs I've had in healthcare in Washington, people work together to make sure they give the best. So that's just a little bit of my experiences of why I feel like Washington is a leader in management of health data.
Great. Any other comments from the panel?
I have some. This might touch on a future of data a little bit, but the state of Washington, or rather Healthcare Authority, is involved in working on developing a community information exchange. Janice, you mentioned earlier about social determinants. That's something that we have in the works right now. And regarding that, it's to help with coordinating between community resources and create linkages, meaningful, appropriate linkages between those resources. So that's definitely something that we have on the horizon, is working on community information exchange. And the other part of that is the notion of consent management. This is because we're talking about further integrating physical and behavioral health care. There are certain aspects that are protected by like the 42 Part 2 CFR or CFR 42 Part 2 regarding substance use disorder. So the healthcare authority is also engaged in an RFP approach, request for proposal, to developing a consent management that would work for multiple platforms. So when you talk about, how is Washington innovating or being a leader in certain areas, we're working on the furthering community information exchange and the consent management as well to further appropriately share information. So that's just a couple of the things that we're working on.
I think Washington State, from the public health standpoint, is I think definitely a leader and an innovator in what we're doing in the public health response. I mean, we've been on the front lines, as Barb said. The first COVID case detected in the U.S., the first COVID death in the U.S. But what makes us leaders is not that we were first; it's that we pivoted, we responded, we engaged, did innovation, and all the while focusing on an equity lens, making sure that we didn't leave any group, any Washingtonian or person residing in our state behind. So I think, to my knowledge, we definitely more than any state in the country, and perhaps more than any country on the planet, have our systems accessible in 36 to 42 languages, depending on what's possible. And having that kind of opportunity to share information out that's been interpreted by public health and making recommendations to the public, we've set a bar, and I think that other states may never catch up with us, but that's okay. Our charge is to continue to provide that leadership and to help raise everybody else.
Do you think we are at an advantage because we have big tech organizations like Microsoft in our backyard?
I would be remiss if I didn't say the response, the collaborations, the innovation, because of Microsoft and AWS and the University of Washington in our backyard, which is a world-class institution. That public-private academic partnership is absolutely an advantage, but it's not an advantage that others can't leverage as well. They're in our backyard, so it makes it an obvious collaboration. But I think it's with the cloud. Amazon and Microsoft are in everybody's backyard, so it's not a prerequisite. And every state has a maybe not as world-class as the University of Washington, but has a world-class institution in their backyard as well to partner with in the evaluation and then bringing the science to the table. And that's what I really think is exciting about the field of informatics and what HIMSS and all of us are engaged with.
Brian, can I help you plug WA Notify and ask you a question about the technology companies that partner together to make that happen?
Yeah, it is. It really is. That public-private academic partnership is incredible. it started as a seed of innovation from the Paul Allen School in Computer Science at the University of Washington, was shared as a capability with Apple and Google to build that protocol for Bluetooth exchange into the respective operating systems of those two platforms. And then, but that's not enough. For it to be a useful tool, it has to be engaged with public health. So the collaboration that in partnership with Apple, Google, and Microsoft Research extended into a partnership with APHL, the Association of Public Health Laboratories, to create an interoperable environment that you can take Law Notify into other states in the US, and it works perfectly interoperable. You don't have to just stay in Washington for that tool to help protect you and your community. So it's, and we literally could not have done it without our technology partners being willing to come to the table, doing that resource free of charge to public health, to provide that tool in our toolkit for response. And we can't go back now that we know what's possible. I think we're going to be looking to use these kinds of innovations for other disease processes, and to continue to squash the pandemic.
And it looks like Ian had mentioned the DOH dashboard is another example of one of the results of the public/private partnerships.
Absolutely.
Cool.
And an award winning. People have looked to Washington State's data sharing in that dashboard, and complimented us on our transparency. So,
That's awesome.
but doing it in a way that protects individuals' information first and foremost.
Great. So what are some challenges we may be facing or may face in the future here in Washington State, if any?
This is Janice. I can think of one. Because we are a forward-thinking state, and we've really advanced the collection of demographics. Hopefully, everything is kept privately, and with the advent of socially determined health and community information exchange, we really have to ensure that some of the information is kept as private as health information, right? I often use the example of, it could be a pregnant mother with a child who loses her housing and maybe has a substance use past, right? And so you don't want that information getting out to anybody, and it's been a really kind of a high learning curve in the health. I'm very active, like with Health Data Palooza, Academy Health, and across the nation, and measurement stuff. It's interesting to see how many people in health don't look at the social determinants of health as private as it should be. So I think that's going to be a challenge, right? And because I do feel that we should have, social determinants of health are going to be collected everywhere, and we have been doing it for a while, but people's housing, transportation and food can really impact their health. And we need to, really realize, how is this being collected? Is it paper? Do they have, multiple modalities? How is it getting into the systems, and how is it kept private, as well as opt in or opt out? And we tend to be kind of an opt out sort of state. And so we do collect perhaps more data than an opt in. And that's probably one of the smartest things I think anybody can do, is opt out, as long as they really inform them of that. But I think another thing is that, besides the social determinants of health and ensuring that it's kept, that it is kept private, is just the fact that I think we're living in a whole different world right now, and post-COVID, and there's a lot of challenges just within healthcare itself. And and so I think we have a lot to think of there. And I think also that survey fatigue and just data fatigue is very real on all fronts, the frontline workers as well as patient and communities. So I think that's something to think about. Thank you.
And Barb, that's something you're probably faced with all the time is the, note bloat or just having our clinicians spend way too much time charting or documenting rather than, facing the patient themselves. Any other challenges?
Also, another challenge is, just like any other sort of data, how do we collect accurate data? How do we make sure that we're getting quality data? How do we make sure we're involving everybody? How do we educate people? And then how secure is the data that we're collecting? And, just some people I was actually surprised that somebody said when you asked about, are you concerned about your data? And they said it depends on how it's collected. Because usually you'll hear something like, why do you want my data? Like, what are you gonna do with it? What security measures? Like, people are hesitant. And just like leveraging all the healthcare IT tools that we have to make sure we're just continuing to get better is something that I am always concerned about. And then how do we prioritize like our work as well? Like, are we collecting too much data? Are we collecting just enough? Are we focusing on our goals? And, just things like that. I feel like are some of the things that come up, especially in the work I do, which is mainly like clinical data.
Right. You can have all these great tools, but there really needs to be mindfulness and having the right people at the table to decide how and what data you want to collect, especially when you're kind of in an inpatient or clinical setting. Any other comments from the panel?
I think interoperability is always going to be a challenge because not everybody uses Epic. I mean, a lot of people do, but there are a number of other EHR, EMR systems where it would be great speaking personally, if I have a malady, I would like, all of those in my web of care to have my information so they can fix me. But not everybody's system talks seamlessly with everybody else's system. In the business world, we have PCs and Macs. In the medical world, we have Epic, NextGen, Cerner, Allscripts, et cetera, et cetera, et cetera, et cetera. So that's going to be a challenge. And it's good to see there are standards organizations that are working on and pushing things like FHIR interoperability. So you can have point-to-point data exchange. And so I would say definitely interoperability is always something to think about. And another thing is not just with the larger facilities, but also the smaller facilities that may not be as well resourced. You want to make sure that you have everybody speaking the same language in the same amount of ease. And I saw Janice's mute come off, so you've got something to say. Go for it.
Oh, yeah, I know. I think we discussed this in the early. So I'm involved with the Gravity Project. If you're aware of that, we're developing out standards for social determinants of health. I was on the community. I'm still in the community for the last 2 years. Civitas just bought us, or just bought it, whatever, just acquired, right? It's in the process for the last year. And so basically, there's been a number of Z codes that have gone forward. So it's really been able to offer that opportunity for clinicians to be able to utilize, and CMS does recognize this. But I'm also involved with something called the COVID Knowledge Accelerator, because I'm also involved with evidence, developing evidence synthesis and such. And we cannot be interoperable until we have standardized terms for science, right? Scientific standardized terms. So we currently are developing out we have one set finished called CEFCO. I can put it in, it's fever.net, FEVIR.net, the COVID Knowledge Accelerator. And it's really exciting. I'm a lurker. I've been involved for 2 years, but to develop these, it's a global effort actually to develop HL7, and fire resources, because when we get down to the very basics, if the research itself isn't interoperable, then we're just kind of plopping things into the system. So I agree with you. I'm sorry, I didn't think of interoperability myself. Thank you.
Yeah. We're probably, I think one of the biggest, Janice mentioned global, and I think one of the biggest challenges to global interoperability that we all need to be focused on if we're going to pivot and be ready for the next pandemic, and be ready to be a member of a global community is, vaccine interoperability and representation of the vaccines that we have. And I'll probably get in trouble for saying this, but the CDC white card is the most laughable interoperable tool I've ever seen. I mean, it's, yes, the CDC white card was shipped out everywhere, but each institution that I saw giving vaccines used it in a slightly different way. And it's, we really need to elevate our game. And one of the answers to that Oregon, Washington, California participated together in was utilizing an HL7 standard for vaccine verification, the smart health cards. And many of you probably have Verify on your phones, and you can get those QR codes that represent your vaccine digitally and in a way that can't be faked. The challenge is that Washington faces is that the way we represent vaccines in the United States is different than the way that people represent vaccines internationally. We use CVX codes. The rest of the world is using SNOMED codes. We really, I think a challenge we're gonna have is to play on an international stage is to pivot and start thinking beyond our borders. So I'm looking forward to working with you all on accomplishing that transformation.
Great, thank you. Yes, it's a pain. Barb travels a lot, so she would know. All right.
We'll get you a prototype QR code, Barb.
Yeah, there you go.
Yeah, it's funny that you brought that up, because I remember when, COVID happened, and it's already a lot that you have to do just to make sure you're okay with all the requirements to travel. And then you get there, and I don't know, I think in France, you couldn't go to a restaurant without showing your vaccination. And, they'll say you could try to go to a pharmacy. I had a friend from Italy who joined me, but he had his QR codes, everything checked out, but I had to, try to convince them and show it to them. So yeah, that's again interoperability.
I'm working on it, Barb. I'm
Good.
working on it.
Thank you. I'm glad to know.
I'll let you be our prototyper.
Sure. Thank you. Thanks.
Oh, that's cool. So basically it's a QR code that's usable across the world except the States. Is that what you're saying, Barb?
Yeah.
The US doesn't have the same one.
Mm-hmm.
You can't even, like, how airlines will say, upload your information. It's basically not recognized. Is
okay.
What it is.
Yeah. Well, but here's the rub is that the European Union isn't following the standard. That's the unfortunate reality, is that our US card follows the standard, will work here and in Japan and in several other countries, but the European Union kind of went their own way and created their own way of doing it. So we're working with the World Health Organization and the countries of the G20 to try to resolve the situation, and hopefully by the end of the year we'll be at a place where Barb doesn't have to bribe the maitre d' to get into the restaurant.
So who is all working on that, Brian?
Yeah.
I'm interested. Yeah.
Yeah.
I had to do the same thing, Hawaii, right? Anyway.
Yeah, well, our QR codes between Hawaii and Washington should work interoperably.
They did, well, I was there right before we had it, so I had to have a proof of test, right? But yeah, they had their own QR code in the beginning, but who is all working on that you're talking about?
So we're collaborating. The Office of the National Coordinator for Health IT is part of an international effort, but it involves the World Health Organization, members of the G20 pandemic response, which is currently being chaired by Indonesia. And as a result, the meetings that I'm coordinating on occur at 4 a.m. our time. So but it's a labor of love trying to figure out how to get alignment of these different protocols and standards. I'm very hopeful. I think that there's going to be in a connect-a-thon style, and Janice, I know you're familiar with connect-a-thons. We're trying to demonstrate that these Fire-based JSON bundles are can be mapped to one another, so that the true HL7 standard and the almost HL7 standard can be used internationally. But our long-term hope is that before the next pandemic, we come to an agreement about so that we have absolutely rock solid consistency worldwide before it's needed.
Well, that's wonderful. Yeah, it's very important. The COVID end I was working with, if I haven't put it in yet, but McMaster University, it turned into what's called the Evidence Commission. And when you're talking about 4 a.m., I do the same thing on those calls, but then it's like 10 in Africa or whatever, so I prefer 4 a.m. honestly over, 10 p.m. But it's exciting to see what's happening. But so I hope, we all hope for this. And the mpox is something, but I think it's primarily here in the European countries, isn't it, that it's moving currently? Does anybody want to talk about that, or?
I don't know.
We started talking about Washington, and it's telling how we started talking about the rest of the world very, very quickly. We're all connected.
We're really involved with the rest of the world, and they're looking to us. It's interesting, right? So we've made a difference. Yeah, WA Verify is great. So I wanted to say one other thing about a challenge in data when we get down to demographics. So we're big on people self-identifying, and I am big on that too. But the truth is, it's very hard to manage that data, and often people just want to opt out. That's the opt-out opportunity. And so it's, when we really look at a population level in our state, because we are progressive in this area, that is a challenge, and because we don't want whoever is taking the data assigning something to a person, right? But I don't know if anybody has anything else to say on that, how the state manages it, or Barb or anybody.
I feel like depending on the data, I can only speak for mostly clinical data. You do have organizations that come in and make sure that, you're reporting the right data. Quality is huge. And also you have like the Joint Commission or, voluntary boards that do that, or state, and then like giving an example with COVID data. So I previously worked in lab. I get a positive result, report that, notify the physician, and then eventually it goes to Seattle, like public health, right? So you start somewhere with this data and it travels all to all the various spots that it's supposed to. And then, eventually decisions are made or analytics is done, specifically for quantitative data or even qualitative. So I feel like it starts somewhere. We have all our checks and balances that we have to stick to, and these checks and balances travel with this data as it goes. I'm trying to simplify it and speak in simple terms just so everyone can understand what I'm saying. So it never stops. The checks and balances continue to go with it throughout the whole process. Even after we're done with this data that we've given to whoever we've given, we have records that we store for up to 8 years, 8 or 10 years. We can't destroy these, records. And then, storage in the cloud. I think that's, that goes without saying, but we're still not there. We're still not, we still have rooms with so much like paper data stored, so yeah, so the checks and balances are always there. Quality is always, working at somewhere like UW Medical Center or even Skagit, we always have quality department is literally everywhere. So there's checks and balances and they keep going and keep doing it, and there's things that are missed sometimes, obviously, but it's a lot of checks and checking again and making sure and implementing quality measures that make sure this data is vetted as it goes. So yeah, that's my input on that.
Great. All right, we have 15 minutes, believe it or not. That went by fast. So poll question number 3, has this discussion raised more questions and concerns about your data? If yes, type them in the chat. And also, if you have any questions, please post them in the chat. As I believe this next section is, yep, we're doing a Q&A. We also like to get feedback on how you think the event went, what kind of topics you'd like to see next. So if you scan the QR code, and I'll also put the link in the chat, feel free to fill that out. But in the meantime, again, this is your time to pose any questions you may have for the panelists. Put that there.
I actually have a question on quality, because I work in developing quality measurement or, the endorsing of it. But in truth, I don't know how my clinical, like the core set or the UDS measures, they're collected locally. And then what happens? How does that go up the food chain in Washington State? Does anybody know that? Dennis?
Not in my area of expertise.
So I can kind of weigh in on that a little bit.
Oh, great.
This is dated a little bit. I work for Providence Health and Services, and I went up to Skagit for a while. Typically on a monthly basis, a lot of the healthcare organizations are they subscribe to quality organizations like Leapfrog, and so this information is gathered on a collector basis. They don't have a direct live feed. It's more like a reported, and they're looking for specific types of measurements, which is stripped of patient data, things, specific quality metrics, some of your quality indicators like present on admission for certain infections. So they'll go through, they'll collect that, they'll collect the POA flags off of whatever EHR they're doing, and then send that as a quality metric. And so the quality reporting organization will look for specific metrics, and that's what gets sent up. But it's usually very voluntary. They have to subscribe to it. They have to subscribe to whatever class that they're looking at. Sometimes they will not have the reporting for a specific area. They're not looking at, for example, I think that some of the organizations that I was working with opted out of labor and delivery. Even though they had labor and delivery, they weren't collecting the data that Leapfrog and some of the other QM organizations were looking for. But they do it on a monthly basis. It's a monthly subscription. That's where people can look and see what's going on. Most of the other quality metrics are there as a result of an incident, a sentinel incident, a near miss, not necessarily a near miss, but a never event. When those never events happen, there's a lot of collection. There's a lot of dialogue between the reporting body like CMS to make sure that this was actually a reportable event. And so these don't automatically get triggered. They're sometimes gone through the quality department to make sure that this is categorized as a reportable event before they take and send it out of the quality department. So that's been my experience.
Thank you. I didn't know that. I mean, I didn't know how that worked. The UDS is actually community health centers. That's what I have more knowledge on, like with the HCA and such. And it goes up because there's all primary care doctors receive, there's financial backing to their meeting thresholds in the UDS uniform, no matter what primary care doctor there is. So, thank you.
Okay, thank you. Any questions from our attendees?
I don't have a question so much as an ask.
Mhm.
And I'll put this information in the chat. But as the healthcare authority gets closer to evolving its electronic consent management solution to something that we can then put or test out, we're very keen on looking to partner with someone who can pilot that with us. So, and that will probably be, I want to say, well, I'll say 2023 because it's easy, but I just put my contact information in there. So at some point we'll be interested to pilot it. So if you are interested or know someone who is interested, please reach out.
Great, thank you. All right, 519. So just a little plug on our upcoming events. We're constantly finding topics to share with you and events to have. So this can be found on our chapter site. Our next one is on EHR optimization. So that's actually a collaboration with Providence and the PMI. So I think this is eligible for credits through PMI. We were supposed to have a Future of Healthcare Summit in October, and we actually just decided to move that to next year and have a smaller event in the fall. So more details to come on that. And then our Student Engagement Committee, they've formulated a Careers in Informatics Spotlight Series. So we have two coming up, one in November and one in February. So again, you can find all this information on our chapter site. Otherwise, here are some ways you can get involved. A bigger one is we're always looking for volunteers, or if you're interested in joining a committee, please reach out to us. Otherwise, you can connect with us via LinkedIn, Twitter, and then Your Accelerate, which is a HIMSS platform. So on behalf of the board, I wanted to thank our panelists, Dr. Bryant Karras, Barb, Dennis, Janice, and all our attendees. Thank you so much for your time and take care. And again, I'll send a link out when this video has been uploaded to YouTube. Thank you.
Thanks for the invite. Take care, everyone.
Bye. Take care.
Bye.
Thank you.
Bye-bye.